Good morning, everyone, and you were just witnessing Dr. Hamazaki doing the antegrade preparation for the retrograde approach. Nothing can be better and easier for me to explain the next subsequent slides. So as all you know, there are four options of crossing a CTO, be it antegrade or retrograde. It is true lumen to true lumen or dissection and re-entry. And this algorithm you have been seeing since yesterday. Whenever you have an ambiguous proximal cap or poor distal target, appropriate intervention collaterals, major side branch at the distal cap, you have a retrograde approach. If it is a long lesion, you go for a antegrade re-entry, and if it is a short, you can make it a both true lumen to true lumen, and this is how it has been demonstrated. So the classic concept is, if you have a retrograde channel cross, you can do a retrograde wire cross or a kissing wire cross, and if it fails, you can go for a cart or reverse cart. And the three fundamental steps of this are antegrade dissection, retrograde dissection, and creating a common subintimal space. And this is where the antegrade preparation role lies in the reverse cart, where you dilate the antegrade CTO part, as shown in this middle diagram, and try to enter this common subintimal space with the retrograde wire. This is how, as an animation, you go for this. Your wire has crossed the antegrade, and this is the antegrade balloon, and it makes a space, and you can re-enter. So, if you look at the classic concept, that is retrograde wire cross and or the kissing wire cross, and if it fails, to go for cart and reverse cart. Nowadays, this retrograde wire cross and kissing are least preferred, because it has been shown that it crosses a lot of dissection planes, and switching over to a conventional cart becomes very difficult. So the difference between the conventional reverse cart approach and the contemporary approach is, in the contemporary approach, what you do is select for a very low profile balloon and just keep it in the distal and try to enter even without the wire being overlapping. So here you can see a classical case of a CTO. This was a 54-year-old gentleman. He had been attempted for a circ an earlier occasion, and that's the septal collaterals. And if you can look in here, we have just crossed the distal cap, and that's a balloon there. And this, with an inflated balloon, what we are trying to do is to enter the common subintimal space with the retrograde wire. And the first attempt was not successful, so we try that again, and now we have entered the common subintimal space, and rest becomes easier. Then you can easily externalize the wire and then go ahead and finish the procedure. So in the second case, this is again, this is a 64-year-old gentleman. He had again a circumflex tight occlusion, where an antegrade approach has been tried and some other specialty, and it didn't have anything except for a huge loop of epicardial. You can see here the epicardial collaterals. And my wire had gone to the OM2, and then it's gone to the OM1, so I know this is in the true space. And then again we antegradely wire that, create a common subintimal space, and re-enter this. Fortunately, unfortunately, the antegrade wire also went in, but if you look at the antegrade wire, this OM2 which my retrograde wire had gone in, so this is a very slow flow, so I'm sure that this is in the subintimal space. So I deliberately wanted this retrograde wire, and once I made it re-enter the common space, re-enter into 2 lumen, finish the procedure with stenting just up to the OM level so as to preserve the branch. And this is the third case. This was a very difficult case. A patient, 68-year-old gentleman who had a bypass done in 2004, and I had done an angioplasty to his venous graft and the proximal OM branch through the venous graft. And now he has come with a true posterior MI, middle of the night. And all we can see here, this is the CTO, this is way back from 2004, and this is the occluded graft here, venous graft. It's not coming. So this is the occluded vein graft. So this is at middle of night. And at that point of time, I tried to go for an antegrade, although that was an ambiguous term, but I thought this stent slot will give me some view about this, but I was nowhere able to do that. So before abandoning, I thought, let me look at the venous graft, and all I can see here now, the venous graft has a little bit opened up, and I can see some channel being there. So I thought this is best to use it as a retrograde conduit. And this is the retrogradely I am starting, and then I'm again not in the true lumen space here. So try to connect with creating a common subintimal space, and then could finish up the procedure. That took me almost the entire night, and finish off. So this is a tip inside the microcatheter, and with a drug-eluting balloon inside the stent and 2 stents, and this was very difficult. I had to angioscope that with a very calcified lesion. 2 stents with a guide liner I could position. This was the final result. So there are sometimes some useful adjuncts also after the antegrade approach which you need for the retrograde technique. And this may be, in the subintimal space in the form of IVUS guidance, which was discussed this morning, using some intracoronary snares, guide catheter extension, stents, and knuckle wiring technique. Also some of the techniques, adjunct techniques to externalize the retrograde wire using snares, tip-in methods, which I just showed, and dedicated wires. So this is how you use an IVUS catheter after the antegrade preparation to enter the common intimal space. A guide liner where it has multiple use, it stabilizes the proximal channel, provides target, and it helps you to reposition again, and it might even help you to take in the wire inside. Sometimes you used a temporary stent and basket-like snare, which is called Sotener. This is not available in our country, and this is how it works. You can snare after the antegrade preparation the wire inside and take this out. So to conclude, the reverse cast is most commonly used retrograde CTO crossing strategy. The contemporary reverse cast should be used without attempts for retrograde wire crossing and or kissing wire technique. And the antegrade ballooning prep is performed before the retrograde wiring at reverse card point. And bigger balloon, that is 1:1, is not necessarily. In the contemporary method, you use a very small low profile balloon, which was being demonstrated here. And this decreases the chances of use of IVUS. Thank you.